Okay, I think we're going to get cracking because it's just gone, giving everybody a couple of minutes. So I'll just give a brief introduction. So for those people who don't know me, my name's Chris Green. I'm the Head of Informatics for the Emergency Care Improvement Support Team at NHS Improvement in England. So what we're going to do is the session is going to take two parts. We'll have a look at a brief presentation, which will go into some of the inner workings of the model and why we started to do demand capacity planning. And then I'll go on to talk about the model itself and give a demonstration for that time. So if anyone does have any questions, please feel free to put in the chat box. I hope you all know how to use that functionality within Teams. So the first thing to say really about this model is the biggest cap is that a lot of people look at modelling in terms of a final solution to something. And this is a quote I always use whenever I do any of the modelling, whether it's ED staffing, acute paediatric bed modelling or anything like that, is that this quote by George Box has been attributed to a few different people, but this is the one I always use. And he said that all models are wrong, but some are useful. And I think that's a major thing to be wary of around using tools, is they are seen to be the final solution. They're seen to be well, if we just did this, this would happen. These, throughout this exercise, you have to understand that doing any type of demand and capacity planning is all a technical exercise. It's not kind of a one-on-one does equal two. So if we did this, this would happen. What it does provide you to do is it provides a solution whereby you can take some of your anecdotal evidence that you are living and breathing with every day, put this through the model, and it can forecast how many beds you will need. So there's a couple of other things I kind of do want to mention. So as an analyst myself of about 19 years in the NHS, working for a trust for 11 years and working for various other organisations, I can't stress this enough, is that data can't do anything. I've seen on Twitter and a few other places as well where people kind of say, that data has done this or information has done that. It does not have the ability to do that. People who are operational and clinical, those are the people that make the decisions that can influence change. But what they can do is they can use data to really help identify areas that they want to improve. And when I worked at a trust, we developed an information strategy, and it was really kind of summed up in the term of data to action. So we've kind of got these four different pillars. So we've got data, and obviously data is just a number. It's pretty meaningless, to be fair. But what a good analyst should be able to do is they should be able to turn that data into a bit of information. So put it into a little bit of context, maybe put it into a graph of some description, maybe put it into a dashboard, but then really moving on to intelligence. So actually then kind of saying, well, actually, it's been going up. Well, the reason why it's been going up is because of X, Y, or Z. And then working with operational clinical people, really understanding about, well, if we were to be able to make this change, this is something that could happen off the back of that. And one of the large areas around this is being aware of assumptions. So we all know the quote around assumptions, so I'm not going to say it, but I really want you to be aware of the assumptions that are being made. So just by saying, well, if we did this, this would happen, that's not going to be the case. If any of you read the book Free Economics and Super Economics, they're absolutely fantastic in terms of looking at assumptions, and just because this happened, assuming that something else is going to happen. It doesn't work like that. If it was, then far more of this modelling would be much more in the public domain. And really what I also want to say about this tool is that it's not a prescriptive tool. I've been fortunate enough to go around to a lot of organisations around the country whilst I've been doing this job for the past 5 years, and I've seen some absolutely fantastic tools which people have available to them. This is not a prescriptive thing. This isn't you must use this tool. What we're saying is this is a tool that is available. It's free to use. You can download it from the NHS Futures website by the end of the week, and you can kind of use this to your own satisfaction. You can do with it whatever you want to. And when I go through about how the model works, how you put the data in and what it kicks out of the back of it, you'll be aware of some of the things that you can do with it. So the other slide around assumptions is that this is not an operational tool, and that might be a little bit confusing for some people, but it's much more of a strategic forecast tool than an operational tool. It will not tell you how many beds your hospital is going to need tomorrow and the next day and going into the weekend. If you want to do that, there is a few different tools available to you. I know on the ECIST UEC dashboard that many of you will receive on a daily basis, that does have a forecast for the next 7 days. And you can have a look at the forecast for A&E attendances. You can have a look at the forecast for multiple other metrics over the next 7 days. But that is not what this tool is for. This model will tell you how many beds you're going to need over the next 15 months, so you can strategically plan what is going to happen. And this particularly happens around when organisations are doing winter planning. So I've been working with a lot of organisations at the latter stages of last year around putting this model to use whilst they were writing their winter plans, so that it's not just well, we're going to put in 20 beds because of this. It's actually knowing that 20 beds will be enough, and if it won't be enough, what are the mitigating factors around that? The next assumption is that broadly right is better than precisely wrong. When I used to work in an organisation, we used to do forecasting for A&E attendances. And let's say, for example, that I predicted today was going to be 210 and actually 215 people turned up. I'd often be told that my forecast was wrong and that we had a ridiculously high level of attendances coming through the front door. What I say to people is that I don't give a precise number around what is going to happen. I will give a variability. So we'll use things like statistical process control to try and understand what the process limits are around something, to understand that broadly right is better than precisely wrong. If I do just give one number for one particular thing, it's quite hard to hit. And the last assumption is that if it doesn't feel right, it's not right. I don't work in any of your organisations. I work for NHS England. I don't work for East Kent or Sunderland or who I'm speaking to this afternoon. So I don't understand all of the whys and wherefores around some of the data, some of the operational and clinical things that go on in your organisation. So if I was to work with you and we were to put your data into the model, and you kind of like say, well, actually, Chris, it doesn't feel like we have that many patients, or it doesn't feel like that's our length of stay, then it's not right and we'll need to go back to the model. The model has been tried and tested for a number of organisations, and the existing model has been used in around 40 organisations over the past 5 years. And it's been well used by organisations to look at their future activity, their length of stay, their capacity that's going to be required. So where are we now? I just want to kind of provide a little bit of context around this. Obviously, you guys are living and breathing this every day, but I kind of wanted to provide a little bit of national context to where we are. So since February 2020, all metrics have seen significant improvement. I've seen some people write on slides that all metrics have seen a significant increase. That's not true, particularly around occupied beds, which has seen a significant reduction. And what we can see on the graph on the right-hand side is a standard statistical process control chart for occupied beds for the whole of the country. And we can see that right on the left-hand side of that graph, around about the 19th, 20th of March, when the new discharge guidance was disseminated, we can then see that there was a significant reduction in occupied beds, which is fantastic, freeing up capacity in the acute sector. But what we can also see is that ever since kind of like the middle stages of April, it's just been continuing to increase. And now, roughly over the past 7 days, we've been about 85 to 90% of, quote, normal activity. But what we have seen in that is still we've seen significant variation. So the graph on the left-hand side is a scatter plot, and every grey dot is every trust in the country. And what it does is it's looking at the proportional change since February. So the reason why I've chosen February as a baseline position is that February was the last full month of, quote, normal data. And what we can see is that on the x-axis, we've got the proportional change in long length of stay patients, and that's patients with a length of stay of 21 days or more. And on the y-axis, we've got the proportional change in beds occupied or occupied bed days. And what is really interesting is that some organisations have seen a really significant reduction in their long length of stay patients, and that's on the x-axis. And you can see that that's kind of upwards of kind of 60, 70, 80% of reduction in their long stay patients. But some organisations haven't. Some organisations are only, I say only, have only seen a 10, 15, 20% reduction. And then equally having a look at occupied bed days, Some organisations have seen a minimal change, and right in the middle at the top, only a couple of percent change. But then other organisations have seen a 55% change. And what we've used this for is it's not being used as a punitive thing. It's more being used to understand what organisations have done, why they've done it, when they've done it, and whether that can be replicated in other areas. So particularly when we've been looking at sub-regions, what we've wanted to be able to do is understand what they've done and whether it can be used in other organisations. So let's go on to have a look at the new bed model. So for those people that have used the existing model, it looks vaguely similar. It uses the same font, uses the same standard graphs, but what I've tried to do is I've tried to simplify this. So in some ways it's simpler, but from a technical perspective, it's actually much more complex. And the reason why it's more complex is you'll see up in the top left-hand box, you'll see that you can still select between the whole of division, the whole of medicine, the whole of surgery. But what you can also do now is you can also go down to a specialty level. So in medicine, if I wanted to have a look at gastroenterology or general medicine or healthcare of the elderly, I could do that. Then equally, for example, if I wanted to have a look at admission type, I could then sub-split the specialties down to either elective or non-elective levels of activity. And what this is going to be really helpful for is really helpful for organisations to understand, particularly around their planned care, so we can understand what impact their recovery trajectory on their RTT position will have on their demand, their length of stay, and how many beds they're going to need. But just using the top two graphs, we've got the first graph is the amount of patients that we see on a monthly basis, and our historical activity in terms of demand is in blue, and our forecasted activity is in black. And exactly the same thing for length of stay. We've got the historical in blue, and we've got the forecasted length of stay in black. As with the previous model, you can change bed occupancy. So because I've got my amount of patients I'm going to see, and because I've got the amount of time they're going to spend with me, that will then tell me how many beds I'm going to require. And we can show on our on the beds required graph, we've got the red line, which is our solid funded bed base. The blue line is how many beds we've used in the past, and the black line is how many beds the model will think we're going to use in the future. And then over on the right hand side, this graph will show you by month how many beds you are short, which will be below the line, or if there was a surplus, it would be above the line into the positive figures. What you can also do is you can also change your occupancy level. So there's been a lot of talk around, I know historical, when the King's Fund and Nuffield were starting to write about 85%, which a lot of people were quite wary of, quite nervous of. You can change this to whatever you want. And I'll show you how that works in the model when we go to that in a couple of minutes' time. What the model will also allow you to do is will also allow you to have a look at all of your specialties within your division, and it will show you the calculated growth that the model has automatically calculated, split by specialty. And then if we just have a look over here at cardiology, we can have a look. The blue line is for the whole of the specialty. The orange bar is for the elective growth, and the grey bar is for non-elective growth. So you can see that for cardiology, for example, there's been a phenomenal 70% increase in their activity. And that's because of, for this particular organisation I did this for, they took over a provision of service from a neighbouring organisation. But what this graph will just do is will just enable you to have a look at all of your specialties within the division that you've selected so that you can make any necessary changes. So then when we get down to scenarios, so the previous model was fairly limited in terms of the scenarios that you could select. So it only had 4 scenarios, and you couldn't put in multiple different scenarios. So the workings behind this new model allow you to put in multiple scenarios and up to 50 different scenarios that you want to put into this model. I doubt that anybody will actually put in 50 scenarios, but I just thought I'd put in quite a few just in case anybody wanted to do that. And we'll go on to talk about how this actually works in principle in a couple of minutes' time. But I'll just show you that you can select from the drop-down boxes all of your divisions. You can select from the drop-down box your specialty, and you can select your admission types. And then this will then show you for your selection what your current length of stay is and what your current forecast demand is as well. and then we can just make any changes, and I'll show you how that works in the model. So when you've made the changes to the scenarios, what you'll see is the model will be pretty much all similar. But what you will then see is you will then say that the current prediction is in grey. So we've still got our blue line. Our blue line doesn't change. Can we just make sure everybody's on mute, please, just so we don't get any feedback? So on the blue line, we've got the historical activity. On the grey line, we've got the
5 minutes and I'm in the middle of a meeting.
Current prediction. And on the black line, we've got what will happen based upon the scenarios that are going to happen. So then what we've got down here is we've then still got our solid red line, which is our funded bed base. But then what you'll see is we've now got a change between the blue line and the grey line. And this can be better evidenced over here. Between each month has then got 2 bars. It's got the grey bar if we did nothing, and the black bar if we did make those changes that we said in the scenario selection. So I'm just going to come off there and see if anybody has got any questions. Will the presentation be sent out? Yeah, absolutely. The presentation will be sent out later on this afternoon. Happy to take any questions if anyone's got any, or if not, we'll just go on to demonstrate the model. Is it a specialty point of admission? Yes. So you can go into the model when we come on to talk about this. When I show you the model in a couple of minutes' time, the data, and there's somebody else has put what's the data source. I'll show you what the data source is in the model, how that works. It's a very, very simple data set. I think when the because I used to work at a trust, I know what data is easily obtainable. And it will just be a very, very simple extract of your inpatient data warehouse table if you do have one. And if you did have to combine some of your data tables, that surely won't be a problem at all. Artie, I probably won't go through the last slide because I'll just go through it on the actual data model itself. Thank you. Okay, so let's go through and have a look at the model itself. So here we've got the model. It looks identical to what it had in the trust, in the slide deck. We still, once again, this is exactly the same as well for this particular organisation. I've blanked out who they are, but this is an active project work that I'm working on this current organisation. And so we'll just go through about how you can select this. So I can easily just say, for example, if I want to change specialty, and I'll just show you how simple that is. So if I wanted to then have a look at general medicine, a lot of people have said, why have I kept it in Excel? The reason why I've kept it in Excel is that everyone uses it, or the vast majority of people use it. People are accustomed to how you navigate around Excel, what you can do with it. So that's why I've kept it in. And then with the admission type, again, this won't make much change because the vast majority of medical work is all non-elective. But you can make those changes and see how it works. If I was to then say, for example, I'll show you how it works for surgery. And then if we have a look at general surgery, you can see how that changes between non-elective and elective. So really, really quick. So and the reason why I've done that is so that you don't have to take actions from a meeting, from a business meeting you might be in to kind of say, well, I'll just have a look at that. You can be in an operational meeting, a business planning meeting, and you can actually make these tested changes live as you were going through that. So we'll just go back and we'll have a look at the whole of medicine, just to kind of show you how this one all works. Okay, so you can see we've got several tabs down here. The specialty assignment tab is that we don't want to be prescriptive about these things. So particularly around how you assign specialties to a care group division, call it what you will. You can use this table to kind of say, well, actually, we have the spec code of cardiology in surgery, for example. So your BI people will know exactly all of the different specialty codes and what they should be and how they should be mapped. And you can just make these changes as and when you see fit. We'll just go on and have a look at the data. So the data is very, very simple, and when this comes out on Friday, we'll will be slightly more refined. But realistically, this is the only data that you need. So what this basically says is, this is the month that you saw that patient. This is how many patients were seen. This is the division, the specialty, the admission method, and how many bed days that those patients occupied. So, for example, in this top instance, you had one patient for the medical division under accident and emergency, admitted non-electively, and that patient stayed 8 days with you. And that is the only thing. So that data table, which I think for this organisation was about 15,000 rows, so it's nothing major, is the only data that is actually needed and required to populate the model. So what we can then do is that I'll just show you about how you can use the scenario. So, for example, we could be in a business meeting and I could be with my ops director, Paul, and we could be kind of like saying, well, actually, we want to make a few different changes to the medical division. And so we can kind of say, OK, so what we're going to do is in medicine for general medical patients, what we're going to do is we're going to have an increase in patients through ECIST. And it's really important to kind of put in what you're going to do, because if you just say, well, we plan to increase more patients, you really need to kind of say what you're going to be doing. So that's why I've put in a simple narrative there. So you can kind of say, well, actually, although the general medical demand is actually looks like it's decreasing by 4.5%, we think by what we're going to do, it's actually going to increase by 5%. And I know this might be a classic teaching your grandmother to suck eggs, but if you plan it to increase, it needs to be a positive number. And you don't need to put a plus in front of it, but it just needs to be a positive number. If you do expect it to decrease, then you can put in, obviously, a minus 10%. But we'll leave that at 5%. But what we could say is, because of our increase in patients through our ECIST, we could say that we're going to reduce length of stay. So once again, but because we're going to do this, I'm going to type in minus 0.5. But then one of the ops directors for cardiology could say, well, actually, what we plan to do is in cardiology, we plan electively to put more patients through, put more patients significantly through to help with our RTT position. So we can kind of say, well, actually, that's going to increase by 40% increase due to RTT recovery. With numbers and I am words. And we could do that for as well. We could kind of say, well, for medicine, we're actually going to do that for gastroenterology as well. So that for elective work, that's seen a significant reduction, but actually we're going to whack through loads of patients to help through that. And then you can just make as many changes. Like I said, you can put in up to 50 different scenarios into here, and then the model will automatically make those changes. You haven't got to say anything else. You haven't got to do anything else. It will automatically make those changes. So once again, we can kind of see what would happen if we made no changes in the grey line. But if we did make those changes, if we did see more patients to help with our RTT recovery, if we did put more patients through our ECIST activity, we would expect the black line in terms of the level of demand that we would see. And then equally, because we're making some changes, we can then say, well, the grey bar is what would currently have happened, and our black line is what now will happen. And then because of those changes, we can then see actually what our new shortfall will be. And so because of here, and what I'm going to do on the scenario, so you can see that slightly better, I'm actually going to remove the first two scenarios, and I'm going to significantly reduce the length of stay. So you can then say for each of these months, you've got those two bars. So you've got the grey bar is what would happen if we did nothing, and the black bar is what would happen if we put the more patients for our ECIST and reduce our length of stay. And you can really see what significant changes could be made, what significant improvements could be made if we were able to do the scenarios that we said. So that's as complex as the model gets. Okay, I've tried to keep it pretty simple, but it is very, very well used. It kind of stands up. It works off the back of work, piggybacks off the work of somebody called Professor Kate Sylvester, who I had the pleasure of meeting a few years ago. We were just discussing different options around this. This is something that's been tried and tested. So I'll be more than happy to take any questions from anybody. So I'm just going to look at the chat box. Sandra's question was, have you adjusted your demand forecast to account for low admissions in the last weeks? And if so, no. So this isn't an operational tool to kind of say how many beds we're going to need for the next day, the next day, the next day. That's already done on the UEC dashboard, and the forecast methodology for that stands up. So that takes into account relatively recent time period. This is much more of a longer range strategic tool. So if you put in data up to, for example, the end of June, you will understand that it will show a significant decrease and you will need to make those changes into it. So it's a very valid question, but at the moment, what I've advised organisations to do is to put in data where they know is at a relatively quote unquote usual level, and then work out how many beds they're going to use. But you can put that into the model to suggest how many beds would you use if existing levels of admissions and occupied beds were going forward. Joanna said, do I have any STPs using this for community bedded care or rehab care packages? No, but thank you very much, Joanna. That's a great question. The principles are exactly the same. So I've used this model for both acute providers and also community rehab care, because the principle is exactly the same. There's only two things you need, which is the amount of patients you see and the amount of time they spend with you. So can it be used in other organisations? Absolutely, it can do. Kate, so can we add an increase in length of stay due to increased priority? Absolutely, you can. It would just be in the model, in the scenario. You wouldn't make any change to the demand plan. You would just make a change to the length of stay. So although I put in scenario changes for both demand and for length of stay, you don't have to. It could just be one of them. So you could say, for example, our overall plan due to our improvement work is that we plan to see a reduction of 1 day length of stay, which would be a phenomenal reduction. But you could just put in -1 day for anything, and it would do all the calculations for you. Chris has said, how is the length of stay information calculated? Also, how does the model handle patients that are admitted to orthopedics are transferred to elderly care? Okay, so that's a very interesting question. So how is length of stay information calculated? I don't know whether you just mean from admission to discharge. It's based on a spell length of stay. It's not based on episodes. I have worked with a few organisations who wanted to take it down to an episode level rather than a spell due to multiple changes of specialty. But most people just stick to a spell length of stay.
Sorry, Chris, it was actually just to ask where's the data being derived from, because on the sheet that you put in, you said all you need to do is put in the number of bed days, I think it was occupied per month.
Yeah.
So how does the model know where the length of stay comes from? That's what I meant. Apologies.
Yeah. So absolutely. So all it would do is it would sum. So it would look at every single specialty. I can show you the inner workings by this, but a lot of people would just get bored and switch off. But what happens is it sums up all of the bed days. It sums up all of the patients and simply divides the bed days by the number of patients to give you a length of stay. No problem. Thank you. A very interesting question, though, you did say about what if patients are transferred, say, for example, from one division to another. I mean, that doesn't happen that often. What I do suggest is that it's done on discharging specialty rather than admitting specialty. But for those organisations, if that happens a lot in your particular organisation, I would advise you to go down to an episode level rather than a spell level. The only major caveat that I would say around that is no one would recognise those numbers, because obviously people understand spells. They don't necessarily recognise episodes. So you would have a phenomenal amount of episodes and your length of episode would be low. So that's just a slight caveat. But it would still give you the same amount of beds required. Lee Dowson, are the predictions based on average occupancy? So you can, Lee, you can put in into the model, you can put in your own occupancy level. So if you wanted to achieve, for example, 90%, 92%, 95%, whatever it is you wanted to do, you can just put that in there by yourself. And Lee, you also said about elective bed occupancy varies by day of the week. How can you take account of this? So the model doesn't do that. The model does not take into account variation by time of day and by day of week. If you want to do that, I do have other tools available which will take into account in-day swing. So, for example, paediatrics is a really, really good example of that. And I worked with an organisation yesterday, particularly on paediatrics, because paediatrics needs a phenomenal amount of beds during the day, but they don't need them overnight. And so using this type of model for paediatrics would be completely wrong. It would not give you the level of detail you wanted. If anybody does want to have a look at that other in-day variation bed model, we do have our NHS Futures ECIST website, which is about to go live. I do have my own section to that, and on that document, on that page, it details all of the tools that I have available, or we have available to us as a team, and more than happy to take anyone through those. So that's the end of the questions so far. I'm happy to take any more, but that's it in terms of the end of the session. I hope you've all enjoyed that. What I will do is a couple of actions that I took away from the ones on Monday was that I will then send out the presentation from today so that everyone's got a copy of that. And by Friday, I will be sending out the NHS Futures website so that you can log onto that and have a look at the tool. It'll be free to download for anybody to play around with. Hopefully you won't break it, but feel free if you do. What I would say about this, and I've intentionally left it to the end, is I'm not precious about this tool. Okay, like I said right at the beginning, I've seen some fantastic demand capacity tools that organisations have used over the years. And so what I would say is that if you notice something in here that isn't quite right, or you think that actually it would be really good if it could do that, please give me a call, drop me an email, tweet, do whatever you want in terms of contacting me, and I'll happily give you the credit, unless it's really good, in which case I'll take all the credit. But I'm really not precious about this tool. What I want it to be used is I want it to be helpful. Okay, I want organisations, if they need this type of work, don't reinvent the wheel, because there are already tools out there that can help you. So thanks very much, everybody. I hope you enjoy the rest of your Wednesday, and I'll look forward to speaking to you all soon.